Good day everyone, I am Jessica Marie M. Ferrer. I will present the case presentation number 2, the T-cell lymphoma. We have the actual case. A 44-year-old woman presented with a dry, non-productive cough that she had been experienced for 2 to 3 months, intermittent bouts of severe shortness of breath, decreased appetite, and a 20-pound weight loss. Chest radiograph revealed mild bilateral pleural effusion and bilateral pulmonary nodules, with the largest nodule measuring 5 cm in the right upper lobe. The patient was admitted for further evaluation and additional testing was performed. Bone marrow evaluation revealed no morphologic abnormalities, but complex cytogenetics and the same T-cell clone was found as in the lung biopsy. Therefore, a diagnosis was made of stage 4B, peripheral T-cell lymphoma or the PTCL, with T follicular helper or the TFH, with phenotype most consistent with angioimmunoblastic T-cell lymphoma or the AITL. So we have the pathophysiology of this disease. Next. So this image is the pathophysiology of T-cell lymphoma. So T-cell lymphomas are the uncommon and rare subtype of non-Hodgkin lymphomas. This disease group has a poor prognosis compared to their B-cell counterparts. So this article describes the evaluation and management of T-cell lymphomas and highlights the role of the interprofessional team in managing patients with this condition. The lymphoid progenitors exit out of the thymus to form the T-cell. So their antigen detection is mediated through T-cell receptors or the TCR. So we have the CTCL or the cutaneous T-cell lymphomas. Pathogenesis include the inhibition of apoptosis and promoting oncogenesis by targeting the tumor suppressor genes. So alteration of key signaling pathways which include the NOTCH or the NOTCH overexpression, so which helps in cell differentiation and proliferation. Fast underexpression, dysregulation of GAK3 or the STAT by decreasing function expression of the negative regulators. So the affinity of CTCL to the skin is thought to be mediated through the adhesion receptor mechanism. The cell migrate using the interaction between E-selectin present in the endothelium and cutaneous lymphocyte-associated antigen or the CLA expressed in CTCL cells. So we have the symptoms of T-cell lymphoma. So these symptoms are very widely based on the type of lymphoma, but some of the more common ones are swollen lymph nodes, fever, weight loss, fatigue, itchy skin, and pain in the chest or the abdomen or bones. So these lymphomas occurs when certain genes changes or we call the mutation form within the white blood cells. So however, it is unclear why this happened or whether it is hereditary. So we have the several factors are known to raise the risk of non-Hodgkin lymphoma and possibly the T-cell lymphoma, including the older age, certain viral infections, problem with the immune system. Next, we have the patient history. So this actual case of the T-cell lymphoma, the patient history cannot be presented since there is no indicated pre-existing patient medical condition aside from the signs and symptoms she has. So we have the subjective information of the patient. First, we have the non-productive cough that she had been experiencing for 2 to 3 months. Second, we have the intermittent bouts of severe shortness of breath. Third, decreased appetite. Also, we have the objective information of the patient. First, we have the 20-pound weight loss. Second, mild bilateral pleural effusion and bilateral pulmonary nodules, with the largest nodule measuring 5 cm in the right upper lobe. Third, complex cytogenetics and the same T-cell clone was found as in the lung biopsy. So next, we have the patient assessment. So this patient is not under any drug therapy yet. So therefore, there is a need of drug therapy that has optimum effect to improve the patient condition. Also, we have the primary impression of the patient. A diagnosis was made of stage 4B, peripheral T-cell lymphoma or the PTCL, with T follicular helper or the TFH, phenotype most consistent with angioimmunoblastic T-cell lymphoma or the AITL. Next, we have the clinical practice guidelines. We use the British Journal of Hematology. This is the guidelines for the management of mature T and natural killer cell lymphomas, excluding the cutaneous T cell lymphomas or the CTCL. Next, we have the list of patient symptoms with treatment goals. So first, we have the dry and non-productive cough. So for the goal of treatment, we have the treatment to cough. Next, we have the severe shortness of breath. The goal of treatment is to manage to maintain patient airway. Third, we have the decreased appetite, to manage decreasing appetite. And last, we have the weight loss, to manage the weight loss. So if we have the list of symptoms of the patient, we have also the plan or list of possible solution. So the T-cell lymphoma are rare, and there is a limited survival data for this cancer. So also, each type of T-cell lymphoma is unique and comes with different outcomes. So the National Cancer Institute Surveillance, Epidemiology and End Results or the SEER program has some survival statistics. A stem cell transplant may be recommended when possible. So next, we have the rationale for recommendation, an abbreviation for a chemotherapy combination that is used to treat non-Hodgkin lymphomas and is being studied in the treatment of other types of cancer. So it includes the drugs cyclophosphamide, doxorubicin hydrochloride or the hydroxydianorubicin, vincristine sulfate or the oncovin, and prednisone. So we have the therapy-specific variables. First, the medication. We have the drug cyclophosphamide, doxorubicin hydrochloride or the hydroxydianorubicin, vincristine sulfate or the oncovin, and the prednisone. They are called the CHOP or the CHOP. Second, we have the dosage form of the drugs. First, we have the cyclophosphamide. Second, doxorubicin dihydrochloride. Third, vincristine sulfate are the intravenously. And last, the fourth, prednisone is orally. Third, we have the dose and dosing interval or the frequency. First, we have the cyclophosphamide. We dilute in 250 ml normal saline or dextrose 5% in water and administer over 30 minutes. Second, we have the doxorubicin dihydrochloride. We dilute in 50 ml normal saline or dextrose 5% in water and administer over 3 to 5 minutes. And third one, the vincristine sulfate or the oncovin, dilute in 50 ml normal saline or dextrose 5% in water and administer over 15 to 20 minutes. And lastly, we have the prednisone, administer 30 minutes prior to chemotherapy on day 1 and then every 24 hours on day 2 to 5. So last, we have the drug interaction. So you have a cyclophosphamide, vincristine, and doxorubicin as a drip into your bloodstream or the intravenously. And also we have the prednisolone or the steroid as tablet that you take with or after food. So you might have treatment through a long plastic tube that goes into large vein in your chest. So that is the drug interaction of that drug. So that's all. Thank you.